Okay, well, I guess we should get started. Thank you everyone for attending the Illuminate presentation today. I'm Ruth Barclay. I'm a professor in physical therapy, and I am really pleased to introduce Judy King from the University of Ottawa. I've known Judy for many years. We met when we were both newish PT grads, working at the Ottawa General Hospital many years ago. A few years later, we went on an adventure to Hamilton and completed our master's degrees in health sciences at McMaster University. So Judy is a cherished friend and colleague. Dr. King, Judy, is a physiotherapist and an associate professor in the physiotherapy program at the University of Ottawa. Her person-centered research program encompasses both patient education and education of healthcare students and professionals. Her fields of study include chronic disease management, health literacy, interprofessional education, mentorship, patient safety, and transformative learning. Judy's widely known as a supportive mentor and role model to both students and colleagues, an award-winning teacher and educator, an engaging speaker, and I'd like to add a fantastic travel companion. She'll be presenting today on health literacy in an era of misinformation, challenges and opportunities for interprofessional education and practice. Thanks, Judy.
Sorry, Ruth, I wasn't sure if you were doing the traditional territories acknowledgement or I'm supposed to do it. Sorry.
Okay, I can do it if you want. I am so grateful to have the opportunity to live and work here and experience the beauty of this land as a settler on Treaty 1 territory and the national homeland of the Red River Métis. The University of Manitoba campuses and research spaces are located on original lands of the Anishinaabe, Ininiwak, Anishinaabe, Dakota Oyate, Dene, and Inuit, and on the national homeland of the Red River Métis. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past and present, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration.
Thanks, Ruth. I actually am in Ottawa, so I'd like to acknowledge the land that I'm currently sitting in at the University of Ottawa, and I'm grateful to live, learn, and work and play in the unceded territories of the people of the Algonquin and Anishinaabe Nation. I pay respect to all Indigenous people who call the Greater Ottawa area home from all nations across Canada. I acknowledge the traditional knowledge keepers, both young and old, and I honor their courageous leaders, past, present, and future. So thanks, Ruth, so much. And thanks also to the College of Rehabilitation Science for this wonderful opportunity to present to people across the Winnipeg, Manitoba area, I'm assuming, and possibly even internationally. I'm very happy to present on some topics that are a lot of my loves and I've worked on for many, many years. But they're very extensive topics, and so I could speak on each of them for a number of hours. So I'm going to try over the next maybe 30-40 minutes to sort of introduce some concepts, to talk a little bit about how they interconnect, and hopefully provide some strategies that can be sort of real world activities that folks can do in the next couple of days. So I'm going to talk a bit about health literacy, misinformation, interprofessional education and practice opportunities in these areas, and leave some time for questions. I also recognize it's a challenge to do a virtual talk about these topics. So I'm more than happy to talk to folks after I finish this presentation over the next couple of weeks, individually or with a group, to kind of walk through some of these things. So that's what the analogy of this walking through some forests. Sometimes the path is very clear when we're providing patient education, which I see all of these topics kind of fall through. And we have a direct sort of goal, and it's easy to find. Oftentimes, unfortunately, the path is very confusing. And these days it's getting more and more confusing. It's often going into different directions. So we need to kind of think about sort of that from our perspective when we're providing patient education. What's the big overall objective, and why am I doing this? So a few concepts of health literacy. I know many of you may be at this talk more around the misinformation, but I don't want health literacy to get lost when we start talking about misinformation. So health literacy came from concepts actually from literacy and health. So the concept of people living with limited literacy having challenges in healthcare. So just to give you a sense, so more recent studies in the last few years have found up to 49% of adult Canadians have literacy skills that fall below a high school level, which can negatively, of course, impact their school, their home, and that. Oftentimes, people think, oh, that's someone whose English or French is a second language, and I can appreciate that's complicated. Oftentimes, this is not that. These stats, unfortunately, have stayed pretty consistent over the last couple decades. So we're looking at probably, 30 to 40 people on average who grew up in Canada, who English or French is their first language, have difficulty with literacy skills. And so literacy is a social determinant of health, much more than education. A lot of times we think about educational attainment, but it's the concept of literacy that really is the challenge. So over the last 20 years or so, health literacy became a component or a concept that people probably have heard. The definitions are different, but the one that was sort of rooted in some of the literacy work is that it's a degree to which people are able to access, understand, appraise, and communicate information to then engage with the different health contexts that they have to deal with to promote and maintain good health across a life course. Needless to say, a very complex thing for all of us to do, and even more challenging for someone who may be living with limited literacy. So just some to display or dismiss some myths that are out there. Having limited literacy does not mean limited intelligence or motivation. It's actually the opposite. Folks are living with limited literacy have figured out ways that they can get through life in terms of figuring out situational things. People often don't receive information in a way that is easily understood. And we oftentimes folks, especially patients, may be too embarrassed, stressed, or overwhelmed to ask healthcare providers for further explanations. We have to think about, I'm kind of assuming most folks listening to this are linked somehow with the health professions, the health sciences. So many of the people we interact with, or maybe our friends or family, if you're living with a health condition, these are all the things we're expecting that person to do. Interact with multiple healthcare providers and facilities, coordinate appointment schedules, find their way in hospitals. I'm sure we all have found how clear and easy all signage is in public buildings. That was a joke. Understand and access information from a variety of sources, follow complex chronic illness management programs, and often from different groups. So I might be living with a respiratory problem as well as a cardiac issue. How do I interconnect those? Plan, make changes to my lifestyle, make informed choices and decisions, and be aware of and understand to access care when they need. You can appreciate all of those components have a literacy aspect to them. So this is one of my cute little cartoons I love. It says, unfortunately, animals sometimes lack the necessary skills to communicate with each other. So there's some animals in the car, I think it's a hedgehog, and maybe like a goose or a duck or something, and they say duck. And the draft says, oh, where? So a simple word like duck in English, for example, we have two different meanings for that. And I'll talk a bit more about this in a few minutes. But what are all the different words we use in healthcare that have multiple meanings that seem to be so simple? And it's funny why people don't understand them. So that's the health literacy concepts. We'll talk a little bit about misinformation. This is something that probably, when I first started talking about health literacy, I never even talked about because it wasn't really a thing that we've been talking about then 20 years ago, but it certainly is now. So I'm sure many of us are aware there's two kind of concepts between this information. Misinformation is incorrect or misleading. So it's just wrong kind of thing. The challenge that we are all facing, both professionally and personally now, is the issue of disinformation, which we really need to think of it as like a propaganda, and another terminology sometimes is used as weaponized information. So the intention of this information is actually to get someone to change. There's a goal behind it, so whether it's to buy a certain product, to get someone to promote a certain behavior, that they call it, the attacker in this situation, or the bad actor has other terms you've probably heard now, to have the person to do. So the concept in our head is what happens is called the cognitive hacking. So our brain the propaganda is there to try to get our brain to think a little bit differently. So keeping that in mind, we have to think about all the sources of health information we personally will have, and as well as the people will interact with in healthcare. I moved this list around just the other day because the reality is now, there's a study more recently done by, I think was the Pew Research Institute, found that people under 30, 40% of their health and news information comes from TikTok influencers. So we all have probably known this within our own family or ourselves, even podcasts, advertisements. Another huge area that's going to be, exponentially will be generative AI, whether it's Chat GPT or whatever, in terms of finding and interacting. I think people don't get that. I don't think I understood that. Recently, I listened to, I think it was a Guardian podcast around how Chat GPT, people are using it almost like a friend. So the interaction and how that's dictating people's decision making. And then we get to us and family and friends and the traditional press and other sort of areas. And this is very much found through the the Canadian Medical Association really finds that there is a generational difference. So they, over the last few years, have surveyed Canadians about how they find information and health information. So over the past, this is from 2025's one, I think it was just published at the beginning of the year. So over the past year, Canadians' encounter with health information, misinformation has increased, and I think we all are well aware of that. The news media ecosystem remains highly fragmented by age. So again, where you might be getting information and where your kids are getting it, and maybe if you're blessed to still have parents or grandparents, it may be very different. We're not hearing the same messages at all. Folks who rely mostly on social media remain the most vulnerable, contributing to a significant rise in susceptibility across the population. There's a direct link between misinformation and negative health outcomes compared to last year. More Canadians report delaying medical treatments or straining personal relations and experiencing heightened anxiety due to false health claims. I'll talk about it in a few minutes, but that's some of the tools that and disinformation use is fear and anxiety for people. The current efforts to combat misinformation are falling short of what is needed. Collaborative efforts will be needed to combat the deepening effects of misinformation in our increasingly fragmented medical ecosystem. Now, I'm going to try to figure out how we can be very positive because it's a very challenging time we're all living in. I was very blessed to have parents that almost lived a century, and they recently passed away in the last few years. So I think they would live through different things, and I keep trying to think this time was just a go, and we will get through some of this hard stuff, but it's getting through it. That's not easy. So some of the tools, and again, many of you probably understand or know of these things already. So echo chambers. So this certainly is reinforced with the way the algorithms work on the internet. So I'm looking up something, then it clicks me to something else and goes. So instead of a broad perspective of the information, I'm getting narrower and narrower and going down the rabbit hole. You get what you Google. So it's how it's set up. Again, this was something that has always been used in propaganda. The concept of deep fake, totalitarian regimes used to get people out of photos and different things, but now it is so challenging to know that something has been manipulated. I'm not sure if you've been seeing, I get them when I watch certain things that both the Prime Minister and the Leader of the Opposition are wanting to give me $1,000 a day for something. And I'm intrigued by how they're getting away with a deep fake of our two main leaders in this country. And of course, influencer, which is a word we never even used probably a decade ago, but is the person. And we have to remember this person is getting money for the opinions. They're getting the clickbait. They're getting that. That is how they're getting paid. And then the other thing that some of you I'm sure aware of are the concept of predatory journals. So this started at the time when a lot of journals became available or had the opportunity to publish research right online instead of just having a paper version. So it was, hey, this is fabulous. It will open access. It'll be wonderful. The challenge has been that these journals, which are business making process, do not have peer review, but they're accessible to everyone. So I can pay amount of money maybe it's only a few $100s to publish in that. And I work right at the university. The way kind of I move up the food chain is to publish. That's the currency I need. So you can see how the predatory journals and conferences get perpetuated because it's feeding into a system that was already there. But the average person, and even ourselves, I'm sure some of you may be working in research, will fall for this because unfortunately, some of the predatory journals have names that really look like the other one, or they actually are the old names because the company that was originally publishing those journals don't want to keep publishing. So that published journal title was available to people. So a company bought it, and so you're seeing it, it's from this what was a reputable journal, and go, oh my goodness, oh yes, it must be okay because it's that journal. But nowadays it's all predatory articles. So why does all this work so well? Well, unfortunately, there has been, and we all have seen it and felt it, the mistrust of healthcare professionals over the more recent years, but certainly this has happened for many groups, and it's warranted for many groups because of the terrible healthcare experiences that people have endured and the terrible things that were done, and we know that. So there's been the mistrust. The other thing, certainly in the last 5 or so years when we were living through the height of the pandemic, was to have some sort of certainty. So a lot of this misinformation and disinformation is certain. Like there's no, oh, well, it depends. It's just black or white. Then what's happened now is this group think. So belonging to a group or peer pressure, this tribalism that's been called. And I was listening yesterday to a podcast with Timothy Caulfield, who I'll talk about in a few minutes, who's a researcher at Alberta that's done a lot of work around misinformation. And he was saying there's studies out of the States that your alliances to your political party will dictate more how you're doing in terms of health behavior than your race, your economics, your educational level, all of that. So now, it's the us and them mentality, unfortunately. I talked about a bit about this before, the clickbait. So the algorithms get us to, reinforce that. And we all know it's easier to not make a change than to adapt or adopt a change. And oftentimes in healthcare, we want people to change something, and that's very challenging. And then there's all these biases. So there's the confirmation biases. We find what we're looking for. There's another one called an anchoring one. We rely sort of too heavily on the first piece of information we receive. You may have heard kind of the joke that, nobody goes the second page on Google. So we hit the top 3. And now with generative AI is, doing the work for us. So we're not even going through or scrolling through things now, I'm sure. And the authoritarian bias. So we believe opinions of authority figures. Now, again, those authority figures that may have been when you were growing up, where certain people or certain professions have shifted completely to podcasters or influencers or something like that. And I'm not saying they're not, that they're not some great ones out there, but sort of the vast majority are not there for the greater good. So as I mentioned, Dr. Timothy Caulfield, and many of you probably have already know of him or have read some of his great books or listened to him on podcasts or presentations. So he's done a lot of work in this area, and he had been previous to the pandemic, but certainly since then has really increased in terms of a lot of the great studies and that are coming out of there. So some of the things he says, and this is more personally, as well as things maybe for some of you who have kids, you could think about maybe as well to get them to think about this. But so you see something online, you hear something. So it's trying to pause and reflect. So trying to not be so out, oh my goodness, that's terrible or whatever. So that it's not sort of all at an emotional level. And that sometimes gets the rabbit hole thing going too. Trying to figure out the evidence, so question the evidence. And this is the challenge sometimes these days, of course, but what kind of evidence supports a claim, especially when it seems too good to be true? Promote evidence-based solutions, support and disseminate accurate science-based information to counter the influence of pseudoscience and conspiracy theories. So not even yourself, and I'll talk about it in a few minutes, even your own behavior to not, you click on something or you like something without realizing that you've liked something before you realize maybe it was dis or misinformation and I've just amplified that voice. So understanding the drivers, recognizing that fear and uncertainty, social media algorithms, and ideological polarizations can drive the embrace of misinformation. And it's a real challenge. If everyone you know is believing a certain thing, to go against that. And then it's interesting, there's sort of the way some of the arguments are for certain sort of behaviors that are around mis or disinformation is this concept of health halos. Be aware of misleading phrases like natural or non-GMO, or it's organic, or it's around stem cell. But really, this is making sort of for products, for example, or clean or whatever, or pure. And again, the product is trying to sell the product, and they're trying to make it that, what are you against, not pure things, or you're anti this or anti that. So for yourself, so kind of think about before you're posting or sharing something on social media. And I think we all try to do this, but it's that trying to find empathy and find common ground. And at this point, I'm just chatting a bit for general conversations with people, but as well with patients and families. And I think the other thing that's coming out that I think we all need to do, and I certainly do, is a concept of scientific humility. So talk to patients and their families about how you have changed your mind about something because of the new evidence. So you thought about this, or when you first started as, I'm a physiotherapist, I used to do this. And then from the science, we know that this has changed. So to actually, it's the role modeling or changing your behavior. The other thing is a concept, and again, many of you may have heard of this too, called debunking. So this is actually, and I know this is fraught with challenges, depending on the situation and who you're with and your personal or professional relationship with them. It's been very challenging, but trying to identify what information is potentially false or misleading. So trying to understand what is the component of, what maybe the person is saying, or what the underlying argument is or the premise, let's say, and verify. Can you verify that the information is indeed false or misleading? And again, in healthcare, that can be challenging. I'm not saying it's always easy. Again, it's not always black and white. And disproving, if so, why is the information false or misleading? So it may be a situation where you're opening up a conversation with a patient or family member and trying to both, be empathetic, understand where they're coming from, why are they thinking this certain way without being, adversarial. And again, this is very challenging for us to do. I'm not saying it's easy. The other thing, another word that you may have heard of, is the concept of pre-bunking. So it's trying to, and it's interesting talking about the whole inoculation, when I know a lot of this is around the whole anti-vaccination issues and things. But the concept of trying to almost get the idea and give people tools and strategies to kind of build, they're talking about a mental defense or something against this misinformation, but trying to, kind of prepare them that people may sway their opinion about this or that. And so how this can happen, or how you could try with this, and this might be something also, I'll talk a bit in a few minutes around interprofessional activities you could do. This might be something as a team, if there's some sort of consistent misinformation around a certain thing, maybe that you're providing, or certain service or whatever. But trying to figure out what misinformation are you trying to pre-bunk. So is there some specific thing that is going to be coming out soon and you're wanting to try to figure this out? And who are you trying to reach? And this is like anything for patient education, but who is the audience and what really is your objective with why you want this group to know this or not know this or whatever? And then so that gets around defining your goals. So again, using a sort of an adult learning principle concept, like, is it knowledge or skills you're trying to think about for the audience or the group? Is it attitudes that are going to have to be changed? Is it certain behaviors? And then trying to figure out an approach that may work. So, is it a narrative component? Is it sort of more of a technique? And then the format. So how are you going to provide this material? And again, this is going to take time. It's not at every one you're going to do this, but is there a bigger project or bigger component that you'd like to look at? And then warning, alerting users of attempts to manipulate them. And again, in our heightened environment right now, that's a real challenge, but keeping that in mind to say, other people may want to manipulate this information to go this way or that. And then sort of preemptively kind of answering the questions, or preemptively refusions that you're not, this, you may hear about this, but this is about that. And the other thing is sort of, and this can be a little controversy too, like the concept of giving someone sort of a weakened or a harmless component of a misinformation. Sometimes that can be helpful to get them to understand, okay, for example, something like this or something like that. So again, this might be a strategy to use a bit longer term. So the next little bit, or last little bit of my talk, I'm going to give you some ideas. And this is lovely Ottawa, if you've never been here. We are very blessed to have tulips given to us every year still from the Netherlands, and they are planted in the fall and they come out in the spring. So my idea here is that some of the things I might be talking about today, you might go, yeah, or no, whatever, but there may be one or two that you might use, maybe not right now, but maybe in a couple months you might think about it. So that's about the tulips. So some interprofessional education practice opportunities. So I just wanted to highlight, I think pretty well every competency profile or framework that we have has something to do with communication and that. And I just wanted to highlight, many of you probably already know, but the great Canadian Interprofessional Health Collaborative have updated their framework last year. And certain components or certain domains, I think, really highlighted. Even within the interprofessional team, we have to think about communication, how it's functioning, collaborative leadership, how we're working together to help the patient and their family. Most of our codes of ethics encompass concepts of equity and access and respect. And again, that's around, providing information in a way that the person, the patient, or the person and the family can all use it in a safe way. And then, of course, there's through the patient safety competencies in Canada, there's concepts about making sure that things are clear and concise. And of course, that leads to, decreasing misunderstanding and patient safety events if we do things a bit better. So first, maybe just to do a little reflective practice. So traditionally, and many of us may have been of the vintage, we came into this and we were the health experts. We were the only ones in the room that knew about X. Now that's not the case at all. We need to certainly rebuild trust relationships. Are we really truly person-centered? And we've moved from patient-centered to really person-centered, and that can be really hard for a lot of people to think. Not just, oh, I'm seeing this person for their knee problem, but the whole person is there. And what are some other components I need to think about? And are we using a type of discrimination? Certainly not, which is atrocious, racial, or any other type. But we may also have that whole intellectual. Do we need to be the smartest in the room? Do we have a condescending tone? Are we, open to people asking questions? Or do we kind of stop that question by the way we answer the first question? And I love this one. Patients don't have a language barrier. We do. They speak very well. We just don't happen to speak the language they speak. So we often penalize a person instead of being, open to, okay, a bit of cultural humility. So how are we going to do this? I'd like to try to figure out how we can all help. And then, of course, another term that's more commonly talked about now, but the concept of gaslighting. So meaning that the person is not being believed about their condition. And that's, again, historically, for sure, that doesn't fall into our preconceived ideas. This is often a gender aspect too. Many times women were told, oh, it's just in your head, you don't need to worry about it, when in fact there was, a physiological reason going on. And then really, have we kept up with the evidence? So are we prescribing? Are we advising? Are we giving advice or giving patient education that really is not up to the evidence? We haven't changed it since, we graduated 30 years ago or something like that. I had a professor that used to say, when people say, oh, I've worked for 30 years as a physiotherapist, they would say, well, is that 30 years of experience or 1 year repeated 30 times? And I think we probably all fall in both camps sometimes. So how do we do a better job when we're interacting with patients? So talk a little bit, and I know, this is going to take time, but in the beginning of a relationship, we're building trust and understanding. Taking the time is going to benefit us long term. So, and it's hard not to because of how we do it, but trying not to interrogate or quiz them, but really trying to understand what they already know about their health conditions, especially living with a chronic illness. And sort of because oftentimes there was misunderstanding early on because someone didn't explain things correctly. And people got a little bit mixed up, maybe, and then they've now had friends or family or looked online, and that's kind of confused them a bit more. Another way to open up maybe on what kind of where their information is coming from might be to ask them, so what have you heard in your community about? And that's the definition of community, very big. So it could be physically their community where they're living, but it could be their social media community or some other community. And just, again, it's hard not to, but trying to be very open. Researchers years ago, and I don't think this has changed anymore, have found that patients talk for about 22 seconds before being interrupted. And if we let folks just talk maybe for why they're there for with us and what's going on, it probably will take a minute and a half. But we have this preconceived questions we want to ask the patient. They don't know what those questions are. So they're not answering the way we think they should be. So we start drilling them like they're on a, you know, they're being interrogated on the stand or something. Other huge things, tell patients when you do not know something, but you'll find out. And also that if you've done something wrong or said something wrong or incorrect, admit to it and say that you are sorry. From patient safety research and that, you're not going to get sued because you've done something wrong in terms of to limit any sort of adversarial relationship or whatever around patient safety events. It's shown that if you've done something wrong or said something incorrect and you were sorry, that will dissipate a lot of issues for sure. The other aspect is talk about the weight of evidence, not the balance of evidence. So this is a bit of the misinformation or disinformation tool. So a lot of times you will hear on shows that people say, oh, well, we have, there's this side and there's that side. Well, there's no that side on some topics. Clean water is better. That's that side. There's no balance. Oh, dirty water could be okay. No, so I think we have to watch sort of sometimes when we're using the word evidence or science, that it is the concept of the evidence says this, and this is where it is. And then the other ones around interactions is with patient education and literacy and health, and that is to chart what you've discussed or what patient education you've actually given to gain in more detail. So maybe there's something you've talked about so that the next time you review that, but also other team members can reinforce the same messages. And again, if you take the time at the beginning, that will be really helpful as you go on. So just basic stuff, maybe again, some of you've heard these concepts, and this comes from health literacy, but the idea about using plain language. We often want to say all the things in the fancy languages because that makes us sound smart. But so if a test is positive, is that good or bad? Sometimes it's great if you want to be pregnant. Hey, the test was positive. May not be so good if the blood test shows you have some sort of infection, but it was positive. I always like this one, cardiac event. Usually having an event is something fun. And, we're not person-centered or people-centered if we're always referring to the patient's condition. So the COPD versus the person living with COPD. That's another one I'm always intrigued with. I'm not sure who allied health are, because shouldn't all healthcare professionals be allied to the patient? Because if I'm allied health, who am I allied really with? Not sure about that one. So we could talk about that on another topic. I've just highlighted a few health literacy resources. I have lots. Please feel free to contact me. Helen Osborne is an OT from the Boston area that has done work in health literacy literally for decades. She's got great resources and she's got some great podcasts. So I just wanted to highlight that. A researcher there in Winnipeg that you may know, Joyce Slater, has done a lot of great work in food literacy and a lot of great resources. And this is a project that she's developed and with others around children and youth. So again, health literacy, food literacy, different components of literacy certainly are things that we need to have our children develop early on. I have a colleague here at U of O who's also a new dietitian, and Melissa Fernandez has done some work around the whole concept of social media and food literacy. And again, looking at the space of social media and how that's taken up with many influencers. I'm sure we've all seen them about different types of diets and resources. So some of you may be working in an interprofessional team that's in some clinic area. So this is something you could try to do in the next week or two. So how about you do a patient education audit? So what that is you walk through the sort of the clinic process. It may be physically picking up printed material. You'd be surprised how much printed material it still hangs around certain clinics and that. Also sort of what the process is and talk to each other. And it's going to take a tiny bit of time, but again, hopefully it will help in the long run for you. But what messages do people get, by whom, when? Like kind of do a timeline. And what are they being told along their journey? And are we unfortunately providing conflicting information? So you can see already that if we are, without realizing it, that can lead to an erosion of trust for folks. And is it really an interprofessional approach? So patient education is a great one to be interprofessional, because we all provide it, whether we call it advice or some other word or coaching or whatever, that is around patient education. So are there gaps? Are you assuming that another team member is talking about this? Oh, I'm sure they talked about this, so I'm going to talk about that in my 5 minutes with the patient. And is information being repeated at different points of care? We forget that if we've done it, we check our checklist or maybe in the electronic medical record or whatever. But we need to remember that patients use information when they need it, not when we give it to them. And I've had colleagues say, and talk about, unfortunately, when they're on their journey with cancer, when I had questions, there was no one there to ask. So we all know that at the beginning of a diagnosis or some sort of component, lots of information is given to people. And it's overwhelming and people don't remember it and everything. But we think, oh, well, they've been told that. The other one to think about, are we using the same terms or terminology? And should we have a certain script? Again, it might seem basic. Oh, patients would know this is like that, those two words, like sodium is salt or whatever. But maybe, again, you're stressed, you don't know what's going on, you're hearing different words from different people, and you're not realizing it's the same message. And again, are there resources out of date, wrong or unsafe material? I did this project with some students a couple of years ago, and we just collected all the sort of the physiotherapy information that was paper versions in the hospital at the time. And it's quite interesting how many of those pieces of paper were around when Ruth and I were still working there together a million years ago. So because especially with paper, it's often just kept there. No one sort of takes it. Again, generationally, maybe the young person, someone under 30 is not going to pick up the piece of paper, but you don't know for the older person they might. So if you find out you need to maybe look at or develop some sort of new patient education material, I want to think about using the concept of clear design. So the other one, always get patients and families input and feedback. Do not have every healthcare provider look at it without having families and patients. They're the ones using it. Basic things that sometimes people don't remember, but when in English and French, we read from the left to the right. We want to have lots of white space. We want to have font. Avoid blocked letters or italices, because it's very challenging for us to read that for our eyes. We just kind of block it out, to be honest. We skip over it. And usually the blocked letters are the ones that always like, do this, or warning, don't do this. If you have limited literacy, it's really challenging to read that. So you may skip over it. And then the idea is to use a font like Arial, which doesn't have the little tags on it that Times New Roman might, when you're designing a piece of material that is to be used. Because without the tags, I can find out where the one word finishes and the next word starts. Again, if I have limited literacy, it's a bit more challenging. Times New Roman is used a lot in books, like when we're reading, because it's easy for our eyes to go along. When I'm giving a patient education piece of material, I want this thing first and that thing there, and that's going there, so that it's easy to differentiate for everybody. Oh, on that note, sorry, before I forget, do all this plain language, pilot test it before you translate it, okay? The challenge with translation and interpretation often is the technical words are so complicated that they don't either kind of get translated correctly, or when someone is doing the interpretation verbally, the person doing it, the interpretation, may not know that technical word in that other language, especially if you're working maybe with a family member. They don't, so if you use plain language, that will help everybody. So a couple just to finish off, other ones I want to think about are interprofessional education. So what's our hidden curriculum? In other words, what are the examples we give to students or new grads about patients and maybe people who don't follow what we think they should? And how does that influence how people think? How are we unfortunately labeling certain people or blaming the victim? So my work has always been with folks living with lung and health problems. So society, if someone says, they have lung cancer, the first word or the first sentence is always, oh, did they smoke? Somehow we're blaming the victim for getting lung cancer, even though we don't do that in any other context, it seems. So we want to think about how we use examples and things and reinforce things we don't want to. My other favorite one is non-compliant. The patient is probably not non-compliant. More than likely, they were never given information in a way that made sense to them or were checked that they understood or things like that, because it's very challenging to say, oh, I don't know. And the other thing is we may not have done a good job. So it's a great idea to kind of say to a patient, in terms of to let them know that it's your fault, not their fault that they're not understanding something. So why do we want to do all this? Well, if we improve health literacy for everyone, it's more equitable health outcomes. So I think, depending on the line of the spectrum, if you're politically, on one side, it's more equitable and it's just the right thing to do. On the other side, it saves money and prevents patient safety incidents. So hopefully everyone thinks it's a good idea. Oops. And just to kind of, finish off here. We want to think about, this is from a project and a conference we had many years ago here in Ottawa, but talking to people living with limited literacy and chronic diseases. And they wanted healthcare providers to know that dealing with their health is just one part of their day. They have to have a safe place to live, a decent job, taking care of their families. And again, we're just seeing usually them for a snippet of their life, so we forget that. And they may understand what to do, but don't have the resources to do it. Buy the healthier food, buy the exercise equipment, go to the gym or whatever it happens to be. And so on that, then think about folks with limited literacy in terms of studying and planning and activities, reach them through trusted contacts and adult literacy programs or places like malls or work or school, community centers. And, or going to schools are great places to talk about prevention because the whole family can be involved and they learn from the kids, which I think everyone does. So just to kind of keep all of this in mind. So going forward, let's think about our choices reflecting our hopes for the world and the future instead of our fears. So I'll have opportunity for some questions, and I have a few resources in this document, but I have tons more. I didn't want to overwhelm people with things, but again, if you have questions now or later or want me to link up with you via Zoom, I'm more than happy to do that.
Archie.
Thank you, Judy. That was fantastic. You should be on national television as far as I'm concerned. One area you didn't talk about, but I'm sure you have lots of impressions about it, is the whole business of research and consent forms. And right now I'm serving on an ethics board, and certainly the whole issue of researchers and consent forms, and the consent forms using acronyms, and the consent forms assuming that people know what they're talking about, it's disconcerting. And I think your message should be loud and clear to all researchers. Like, when you write a consent form, run it by folks who don't know anything about what you do.
Yeah.
But it's, for people to sign on to stuff that they don't understand, I mean, it's just not ethical. Archie, thank you for that question. I appreciate it. So I started my PhD almost 25 years ago.
So I did my PhD work with people living with limited literacy and chronic illnesses here in Ottawa, and I interviewed people in adult literacy programs. So I had to go through the University of Ottawa's ethics, and same thing. I made it plain language. I had lots of resources for that. And so I put, if you have any problems, contact these people, like the ethics thing. They didn't want me to use the word problems because what if there were problems? I'm like, yeah, that's why I put the word problems and had to fight them then. And so that was 25 years ago, because my feeling has always been, and I will say this, and people can write this one down, that the ethics boards on the whole, or the consent forums, are not protecting the patients, the clients, the consumers, whatever word we want to use. They are 100% protecting the people that we work for. Whether, and that it's the same, yeah, I'm sure we all have done with the audit, or with the, sorry, with the, many of us, I'm sure, work clinically, or, the clinical world too. The hospital situation is exactly the same. No, now, again, but there is literature, and I can find stuff for you around that. Like, if I misunderstand something because you have not written it plainly, you were at fault. It is not me that's at fault, and so you're going to get sued. You're going to, like, those are the reasons. And the whole literacy, or limited literacy and plain language, a lot of it came from both the UK and a bit the States, but around law, because they realized too, even though we know law, has a whole other thing, but a lot of the, the ones that had the moral compass, they realized, yeah, like, we need to make this plain. So it's very easy. And that's why on a diatribe, but that's also the concept of, don't be producing something that's too complicated if you're translating it into other languages. Because it just takes more time, it's more money, it's physically probably like a piece of paper more, all of those things. But no, I'm with you 100%. And it's a really hard one. I put in my thing, the folks that might be a little bit more in tune, because there's been a lot of work on it, were the people at the McGill, like, so the McGill, and sorry, I always forget what the hospital, the McGill hospitals in Montreal. They did a lot of work in plain language and things like that. And so again, it was there was a lot of work done in the early 2000s, and then became down again. And now it's come up a bit, but it's getting all mixed up with this misinformation and disinformation. And I want us not to forget, there are people living with limited literacy that are having challenges with the information we're trying to give them. So anyways, I'll get off my diatribe.
Thank you.
Moni, I saw you had your hand up before. Did you still have a question? No. Sarah?
Thank you, Judy, for your presentation. I feel I appreciated all of your ideas, and I feel really validated, because lots of the messages you're sharing, I try and share with students also, and you've given a lot of great resources that I think I'll be able to use in my teaching materials. But my question is about AI. So I coordinate our student-led clinic at the University of Manitoba. And recently, I heard about it from somebody, and then I tried it out, and I was like, oh, this is great. So like some patient communication emails and things. I've put them into Chat GPT and said, can you give me a version at a grade 5 reading level in plain language? And I've been pleased with what I've been getting back and found it to be helpful. I'm just wondering if you have any thoughts on doing that. Is it okay? Is it not okay? What to watch for? Stuff like that.
Yeah, great. Thanks, Sarah. And I got a few sort of plain language resources too, just to help you with. So some of that is, again, you want to pilot test it, but the reality is some of the words, just like I used a little cute, I hope it was a cute little humor part about the duck. But we have to think about the word mass, for example. So mass is would be a grade 1 word, but I could, if people are of the Catholic faith, they went to mass, or I could have a mass in my liver, which one's maybe more positive for some folks and one's not so. So that's the challenge with running some of those things. It's the concept of, it's just like Word used to have it and all of them used to have it. It's how we're using those words in healthcare that may be different than, so I think that it's always, what I'm big is pilot tested with the end users, but for me, it's the patients or providers, and to get them, especially usually with the physio stuff, it might be things that we want them to do, like it's a physical thing. is to ask them to, you know, sort of talk aloud or read aloud and ask them to do what it is. So what would that mean to you? And how does that work? And then you can get a sense of, oh, if I put it in that order, that's going to mix them up, because it's things like order and all of that, not just the words we use. Very basic plain language, like if you're using, if you know, we have to use sometimes technical words or abbreviations, you need to put them somewhere that's spelled out. I'm sure we've all read things online and you, for gosh sake, tell me what those letters mean, like honest to God, you know? Yeah. Yeah.
Thank you.
I think it's, but on this other side, I think we have, you know, Chat GPT and all of those, I think they're going to be very fascinating. I'm just starting to work with a colleague around the concept of using it, you know, in more decision making, you know, because people are using it for health decisions, and sometimes, unfortunately, not that great, because people like, you know, some people are using it like a friend. And you kind of think, which could be okay, like, hey, what should I serve for dinner? But also for issues around mental health and stuff. And you're like, oh, hey, I'm not sure about that. So, yeah.
Thanks.
Tony?
Hey, Judy, thank you so much. That was really interesting. I love listening to you talk about literacy. I have a new example for you, for your tool of examples. My mother is not her mother tongue was not English, but she's pretty much fluent, and she was diagnosed with something. I guess I have to be careful about her personal health information. Her internal medicine doctor told her to watch her weight. She came home and told my sisters and said, oh, I can't eat that. The doctor said I'm supposed to watch my weight. I said, Mom, I was there. What the doctor was saying was that you should watch your weight to see if you're gaining weight too quickly in case you have fluid buildup in your ankles, etc. You can imagine what her condition probably is by that. But she thought watch your weight wasn't about fluid retention. She thought watch your weight means that she should eat less and she was over.
Yeah.
Fascinating. Like, I went, where did you get that from?
No,
It's interpretation.
it
And
totally
she's from a generation where women were always being careful not to,
Yeah.
and not to gain weight.
Yeah. Oh, exactly. I know. Well, I had a similar one with my cute little dad near the end of his life. He was in congestive heart failure. And so we were weighing him every day to watch in terms of this is a classic one, it seems, that, you know, for the pill, like how much of the water pill to give him and different things. And I started realizing my dad was not eating as much because he thought we were weighing him because he was weighing too much.
Okay. So yeah, that CHF is exactly what my mom had.
Yeah, and had to
Yes.
reinforce, and I heard the same thing recently from a friend's mother-in-law. So, you know, that's a simple, like, watch your weight. Those words aren't complicated. But that, you know, it's the concept of, you know, you're the think aloud, and you're asking the person to kind of respond back to what you think you've said, you know. So it's the concept of just asking them, so what would you do when you go home? What we've talked a lot about stuff, and I might have got things confused. I mentioned about watch your weight. What are you going to tell your daughter about that, or your spouse when you get home? What do you think that means? Or, you know, or maybe you got to watch, you're not quizzing them, and then you find out you really have done not a good job of explaining something that you thought was very clear, you know. Yeah. So, yeah, no, I think it's always, we see that when we are the recipient, when we're either a recipient of healthcare or our loved ones, and you're like, wow, okay, they're not getting that one at all. No, that just flew right over them. We won't talk about people not speaking loud enough for my cute little dad that had hearing aids, or, you know, glasses and all of that stuff too, like not actually getting the message because they're not hearing it. Yeah.
So Judy, I'm wondering then what strategies would you suggest to explore a person's understanding of information that you've shared with them?
Yeah, so again, it's you know, the concept of trying to get them to you know, kind of explain it to someone else. And so it's using, because sorry, I'll start this again. People think, oh, I would ask questions. Oh yeah, but we all are in certain social situations where we don't want to look like we don't know something, right? And so, you know, I often use the situation for people might be like the car mechanic. So they're going to sell you something or say something, and you're going to go, oh yeah, I'm yeah, of course I need whatever, the $500 whatever. And you realize, oh, okay, I just don't want to show that I don't want to look stupid. I don't want to do certain things or whatever. And you know, one of the things can be called the teach back or show me. So again, you put the onus on you, you know, so, you know, we've talked a lot about different things today. And I just want to make sure I've not done a bad job. So I want to make sure I explained it. Could you tell me what you tell again your friend or your spouse about your condition or what you would do? Now, if it's something physical that they can do, like we, again, as a physio, I might say, I might have confused you. So can you just show me how you're going to do that exercise at home? And like for myself, as a physio, going to a physio, I will get confused, right? I know all the words, I know the exercise, but as a participant, I'm now thinking about a million other things, right? So I think there's that, like put the onus on yourself as a healthcare provider that you might not have done a great job. Because, and that's, I just want to again highlight, we think other team members have said things to patients when they haven't. And it's not their fault, but everyone assumes someone has told them about this. And you realize no one told them about this really important thing.
So Judy has a comment. There's a few comments in the chat about agreement with the change to allied health and
we got to get rid of that one.
and using the term your healthcare team maybe instead of one.
Yeah, that sounds good. Yeah.
I think that's a long-standing thing. I mean, some of us have been barking up that tree for about 20 years, and the ones who use the term aren't changing.
Yeah, well, I think the thing is for all of this, for me, and it became attuned when I started working in this area, is language. It's not like language, but it's the terms we're using and and that's, I think I often talk to the students about, because I work in a bilingual program, you know, they need English and French. They need the technical English, the technical French, but they need like the common English and the common French. But, you know, especially students, they want to sound good. You know, they want to be on the whatever, you know, oh, the pit or something, you know, or Grey's Anatomy or ER. I'm, you know, aging myself here. To sound, you know, because that's trying to build their confidence. But to me, if you can't explain no matter what you do in plain language, then you don't understand it. Like, I'm sure we've all had, right? And that's the whole whatever splaining, whether you're gender stereotype of mansplaining or whatever. Like, if you cannot explain something in plain language that everyone can understand, then you really don't understand your topic. So.
Thanks very much, Judy, for the great presentation. Good discussion. I think we need to cut it off now as people get to other meetings and classes and what have you. So
yeah, and again,
for attending.
Oh, thanks, Ruth, so much. Thank you. I really enjoyed it. And again, I mean it, like, please contact me and we can have a little conversation, or if you're with a team, I can give you some insights or help, or it's sometimes nice just to walk through what your process is, because sometimes that's a bit different, and give you maybe some, I don't know, resources or help. More than happy to do that.
Thanks, everyone. Have a good afternoon.
Thank you, Judy.
You're welcome. Thanks.